would like to present some facts about choledochal cyst before we go to the which is the better technique. We all know that choledochal cyst has various types and forms, and definitely it requires surgery. So, what type of surgery is what we are going to discuss today, or we are going to argue today. And laparoscopic resection of choledochal cyst has become a popular approach, and I think that is also quite acceptable compared to open technique. The number of cases of choledochal cyst may vary from places to places, state to state, region wise, and the treatment strategy is also depending on the surgeon's preference. So, I may prefer something, the other surgeon may prefer something. That totally depends on the surgeon. So, what we are going to do today is what is the best option for the child. And what does the literature says? Literature, if you go through that, about 80% of them will tell Roux-en-Y reconstruction or hepaticojejunostomy is the gold standard for biliary reconstruction. And hepaticoduodenostomy is getting more popular in the era of laparoscopic surgery. So this is what I have found from the literature. But some surgeons who perform hepaticojejunostomy, they do it in open. But when it comes to laparoscopy, the same surgeon will perform it hepaticoduodenostomy. So there is lot of confusion also as to which is the best technique. So let's see what we come up with. I am for hepaticojejunostomy because it is been considered for time immemorial as a gold standard for the treatment of choledochal cyst. Bile draining into the jejunum definitely decreases the likelihood of a biliary reflux, which is seen in hepaticoduodenostomy and which is beneficial for patients prone to bile-induced gastritis. That is one point I would like to be for in favor of hepaticojejunostomy. The other point is the jejunal loop is a further distance from the gastric contents. So the gastric content which comes directly to the jejunal loop reduces the risk of bile reflux and recurrent cholangitis, which we see most oftenly in patients with hepaticoduodenostomy. Since it avoids a direct anastomosis to the stomach or duodenum, there is a lower risk of peptic ulceration at the anastomotic site. If you take a hepaticoduodenostomy, the gastric contents come directly in touch with the anastomosis, and it is coming in touch with the gastric content which is full of acid and other enzymes. So the chances of stricture and cholangitis is much higher, I feel, in hepaticoduodenostomy compared to a hepaticojejunostomy. We are diverting the contents. And there is no chance of hilar cholangiocarcinoma after a choledochal cyst excision if you have done a HJ reconstruction compared to a HD reconstruction. That is my points in favor of hepaticojejunostomy.
Thank you, Dr. Agarwal. You have finished on time. I mean, you have finished before time. Now, may I ask Dr. Ramadwar to present his opinion?
Thank you, sir. What I realized today morning that my opponent actually has been occupying this podium for a long time since morning. So he's got a very distinct advantage of already being on the pitch and playing for a long time. So he's a seasoned campaigner. So I'm just standing in front of him and facing the fastest delivery as we all play cricket. So now HJ, why HJ everybody is doing? The reason was when surgery started for choledochal cyst, initially people anastomosed the choledochal cyst to the duodenum. And then the food would go into the choledochal cyst and stay there and cause lots of complications. So after that, people realized that this is not a good option. So let's put the jejunum. Another reason why surgeons were comfortable with the jejunum, because they were scared of operating on the duodenum. They were scared of operating around the pancreas. And we didn't have good sutures, we didn't have good antibiotics, we didn't have TPN like what we have today. So we are talking about a surgery which was being done in a bullock cart era, and we are all roaming around in beautiful cars, automatic versions, and all kinds of things. So we have two different contrasting events over here. So why do I think that hepaticoduodenostomy is good? Because when I started doing choledochal cyst surgery laparoscopically 21 years back, I was also doing hepaticojejunostomy. And the colleagues of mine who were doing open surgery, they convinced me that hepaticoduodenal anastomosis is much better than the hepaticojejunostomy, and the reasons were it not only is a better way of reintroducing the bile into the GI system, it requires less operative time. It is a much simpler procedure than the hepaticojejunostomy. It obviously reduces the risk of internal hernias or any other small bowel anastomosis issues because of the single anastomosis. Another factor is the length of intestine that is available. Now, if you all remember the anatomy of a newborn baby, the length of the duodenum is somewhere around 6 to 7 centimeters, which grows to 28 to 30 centimeters in adults. So it's not a huge growth that happens. So anastomosis of the duodenum in an area which is much further away from the pylorus is obviously going to create more problems because you are actually bringing the bile duct in front of the pancreatic duct. So you will have pancreatic juices going into the biliary system, inducing what I mentioned about cholangitis and a risk of cholangiocarcinoma. Another reason why cholangiocarcinoma can happen is because nobody is excising the choledochal cyst entirely, going right up to the porta from whatever videos I have seen. People are cutting the choledochal cyst just above the cystic duct junction to the choledochal cyst. That's an incomplete excision. So you are leaving behind a remnant. So that's another point. Now, by doing a duodenal anastomosis, you do achieve a physiological biliary drainage. It obviously gives a lifelong endoscopic access to the biliary tree. And if there is any stricture, any complications, stone formations, it can be treated as a daycare basis rather than doing an open surgery or a laparoscopic surgery as today's fancy of robotic redo surgeries. So all those problems can be avoided since you have a lifelong endoscopic access. So people have published number of papers in open comparing same centers comparing open versus HD versus HJ. I also have my own series of 180 patients, in which 101 patients have undergone HD, laparoscopic HD, and 79 have undergone HJ. They do not have any significant difference in complications. The risk of cholangitis, risk of complications is almost similar, risk of leaks is almost similar. So I feel that hepaticoduodenostomy is a much better option, particularly because of the endoscopic access which is available for lifelong. Thank you very much.
Thank you, Dr. Ramadwar, for again finishing in time. Now, may I ask Dr. Agarwal to give the rebuttal?
Well, whatever Dr. Ramadwar said is acceptable, no doubt about it, but still we have reservations about that in literature. Though I myself have done few hepaticoduodenostomies, I never had any problem. But I was always told by my seniors to do hepaticojejunostomy because that's a time-tested procedure. And what Dr. Ramadwar told, symptomatic reflux gastritis can be a problem as per literature, though I have not seen in my own practice, but it can always be a problem, and that is why most of the people refrain from doing a hepaticoduodenostomy. And the proximity of the bile contents and the gastric contents to the anastomosis. We should remember that when we are talking about physiological, in normal bile duct entering the second part of duodenum, there is always a sphincter. When we are doing an anastomosis, we are not having that sphincter. We are directly anastomosing the common bile duct, common hepatic duct to the duodenum. So there is no sphincter which is preventing the reflux of the bile into the common hepatic duct. And the chances of cholangitis is always higher because of this reason, which makes it prone for more and more cholangitis. And that is the reason why, because the anastomosis is exposed to acid and bile contents, it's more prone for getting stricture in HD compared to HJ, which we don't come across strictures very commonly. And as I told in my previous thing also, because of this exposure to bile and the gastric contents, the chances of cholangiocarcinoma are higher in patients who have undergone hepaticoduodenostomy. And there is a high risk of sump syndrome in patients who have undergone hepaticoduodenostomy. This is previously when surgeons used to join just the choledochal cyst to the duodenum. They never used to excise it. In those cases, the sump syndrome was seen, but nowadays we are excising it, so this complication is very less. And the other fear we have is Duodenum is a very low vascular area compared to a jejunum. So when you do anastomosis, chances of leak may be higher in duodenum compared to a jejunum. If you have a leak in the duodenum, it acts as a very high output fistula compared to a jejunum, where the leak may not be very significant compared to a leak in the duodenum. That is what my rebuttal. Thank you.
Thank you, Dr. Agarwal. Basically, what you said is that since there is no anti-reflux mechanism between the duodenum and the common hepatic duct, the chances of reflux into the biliary system and reflux into the stomach, and there will be more incidence of stricture. And so you think that a long portojejunostomy is a better operation than a portoduodenostomy. And may I now ask Dr. Ramadwar to present his rebuttal?
So I think before I talk about hepaticojejunostomy and against hepaticojejunostomy, let me be very clear about bile gastritis. In normal population, 23 to 60% of normal population has an occasional incidence of bile reflux into the stomach. Patients who undergo laparoscopic cholecystectomy have a continuous flow of bile into their biliary, into the gut. They have a much higher incidence of bile reflux into the stomach and gastritis. Patients who undergo variety of gastric procedures, they also have a much higher incidence of bile gastritis. Patients who have gastroesophageal reflux, a lot of us probably are reaching an age where we all have gastroesophageal reflux, and if you have bile in the stomach, the incidence of adenocarcinoma of the esophagus is much higher. So this I'm talking about the adult scenario. So we are not only dealing with kids, but we are dealing with the entire lifespan of these kids. So why bile gastritis we are giving such a significant importance? The reason for that is the reflux causing adenocarcinoma of the esophagus, and that not pure bile gastritis alone. It has been found even in adults, patients with chronic abdominal pain actually have 23% of patients have bile gastritis. That means bile gastritis or bile reflux into the stomach is a natural phenomenon. So what are we scared of? We are scared of that we are going to increase that bile reflux into the stomach. Now that you will do if you are not doing the anastomosis correctly, you are distorting the pylorus, you are disturbing the pylorus, or you are creating a long loop before the anastomosis in the duodenum by cauterizing the duodenum and mobilizing, and doing the anastomosis much further away onto the duodenum by creating two long limbs of a trousers by which bile can flow into the stomach very easily. And the way to document it is to do a HIDA scan post-operatively in this patient to show if there is any HIDA scan activity in the stomach. And those are the patients who will require follow-up and do they develop any symptoms. Out of my 101 patients, 3 patients had been documented with HIDA scan activity in the stomach. Only 1 patient is symptomatic, treated conservatively without requiring any further treatment. So I think we are giving far too much importance to bile reflux into the stomach rather than dealing with the actual problems. So why am I against hepaticojejunostomy? Well, it takes much longer. It can be technically complex, and now in small babies, I'm seeing people using staplers and creating a lot of issues of space and collateral damage to the tissues, a lot of handling of the bowel. Anastomosis is being done at a much longer distance, 25 to 40 centimeters from the DJ flexure. Now that is going to end up sometimes with a short bowel syndrome in these patients, which is a risk. You have also associated problems of internal herniation, post-operative adhesive obstruction, much longer time to feed. It has 2 anastomosis, so it has got a higher chance of leak, though in my practice I have not found any difference. So in infants, excising jejunal segments might contribute to minor risk of short bowel syndrome, but remember that the figure of 40 centimeters doesn't really apply to infants. You have to remember the size of the child and the entire length of the gut before you have a fixed formula of a length of any anastomosis in a child. So these patients can have a longer hospital stay than HD. My HD patients sometimes go home after day 3, day 4 after surgery. But HJ patient would stay for 5 to 7 days. So that is something which I think it matters a lot for people who are working class. Most of our families are working class people. So they want to get back to their home and they want to get on with their life. So I think HD is much safer option and it is can be done by everybody. And I think today we heard a beautiful presentation from Patna that they are doing HD and they have got absolutely very good results. So I think congratulations to them as well. I think a lot of people are doing HD, so there's nothing wrong with it.
Thank you, Dr. Ramadwar. And You just exceeded the time a little more. But what you said is that you are not really worried about reflux of bile into the stomach, and you have really not much of problem because of the hepatidocoduodenostomy by way of stricture. But I'm surprised that you did not mention anything about pneumobilia. There ought to be some patients with pneumobilia in your series.
So I have pneumobilia in patients who have undergone HG as well as HD. So just doesn't mean anything.
Thank you. And